Good morning. This is William Guyard. I will be discussing computational neuroimaging research in epilepsy. The topics for this talk include an overview of computational methods in epilepsy research with a view towards neuroimaging. This involves available technologies and clinical perspectives that include structure, metabolism, function, perfusion, biochemistry. We will also touch upon connectivity and what this means and how it is measured, that is the metrics, and we will discuss clinical validity of computational neuroscience methods. So what is the level of evidence for the assertion that application of computational methods for analysis of patient-level neurophysiology and neuroimaging data improves epilepsy surgery outcomes? This last portion really is designed to look at essential elements for a neuroimaging study following modified Strobe criteria. The use for imaging in epilepsy is to identify etiology, to identify or confirm the focus, which is critical for epilepsy surgery, to predict outcomes, that is for epilepsy control and cognitive outcomes, to direct the treatment of surgical planning, to identify areas to be spared during epilepsy surgery. This is both cortex and white matter. Also as a biomarker of disease and treatment, and the investigational use to investigate the effect of epilepsy on brain structure and function, and to gain insights into the neurobiology and mechanisms of epilepsy. Thus, there are practical clinical applications that are pre-surgical, surgical, as well as scientific issues. The available technologies that we will discuss today involve MRI, which exists at 1.5T, 3, and 7T, PET and its various ligands, and Spect. I will not be discussing EEG or MEG, that is a topic for others. In terms of structural MRI, one can use this to investigate the gray and white matter structural integrity. One can look at diffusion tensor imaging. One can look at metabolism with MR spectroscopy. 3 Tesla allows one to look at metabolites, 7 Tesla is better, and I will not comment much on this further. One can look at cerebral blood flow using arterial speed labeling techniques, and one can look at functional imaging, which can either be task-based or resting state-based. There are particular challenges in epilepsy studies. Those involve the need for individual level studies versus group studies. Typically, for many studies, especially those that involve functional imaging, there are signal-to-noise issues. Some modalities need to be analyzed as a group, which often requires spatial normalization to a common space. These common spaces involve the Talerac Atlas, the Montreal Neurologic Institute Atlas based off of medical students from McGill, and the Boston Balloon Brain. However, individual epilepsy care requires analysis on an individual basis, so there may be a need to analyze data in individual space. Statistical power is much greater when you have random effects models which require group analysis, and this allows extrapolation of findings to a larger population. So the current standard for group studies are random effects analysis. It is important to grasp the nature of the heterogeneity of your patient population. It is virtually impossible to find a perfectly homogeneous population, and that must be addressed in your study design, in your analysis, and in your discussion. It is important to identify commonalities as well as identify differences. This makes it particularly fun and challenging for submitting for grants and submitting papers, as these issues are ubiquitously present, and they best be addressed in your grants, papers, and introductions. I will discuss MRI first and then move to other modalities. So when you conduct MRI studies, there are a variety of things that can be measured and ascertained, the most common of which have been volumes. You can look at regional volumes, you can look at structural volumes, you can look at gray matter volumes, they may be cortical or subcortical. You can look at white matter volumes. You can also use fractional anisotropy as well as tractography to look at white matter tracts. It is problematic on how tracts may best be quantitated. Here you are looking at diffusibility in 3 planes, and anisotropy, of course, is directionality of diffusion, which is used for white tract mapping. In addition, there are voxel-based studies where one looks at the difference between an individual based on a population for a metric that you are assessing. This requires substantial normal control populations adjusted for age and sometimes for gender, and then to look at how that individual differs, usually 2 or 3 standard deviations from a typical population. These often require atlases. They can be based on gyruses. They can be based on Brodmann's area, lobes, or regions. The commonly used atlases include the Wake Forest Atlas, the Telerik Atlas, and so forth. And they do not all agree on some elements and details. There are a variety of analysis programs available that can be used for structural or functional analysis. One is Statistical Parametric Mapping, or SPM, from the University College of London. AFNI, which was invented in Wisconsin, now is housed at NIMH. There are other software packages available, such as FreeSurfer for structural MRI volume determination and segmentation, Tortoise for tractography, which is housed at NICHD at NIH. And there are other programs as well. They all vary in the user friendliness. They all have advantages. They all have disadvantages. They generally have decent support and a network of users, and it's important to use a program with which you are familiar, and that software development is available and adaptable for your platform and for your needs. For structural MRI, one can draw regions by freehand. This then requires reproducibility and agreement metrics, and as well as training. There are also software programs that have their strengths and limitations. Segmentation is usually based on signal based in gray matter, white matter, and CSF. Some areas are particularly tricky to measure, including the basal ganglia and other subcortical structures. When looking at volumes, one can also look at thickness of cortex, and one can also look at signal intensity. And again, especially when doing these kind of studies, one needs reproducibility and training. So typically one has a training set, and then as you train serial people, you need to do agreement comparisons to make sure there's no bias introduced by different raters. So white matter tracts can also be evaluated. This is a map of using probabilistic DTI, which gives you finer grained resolution of white matter tracts. So in diffusion tensor imaging, one is looking at diffusibility. This is the distance a molecule or water will move. Fractional anisotropy is the directionality of that water molecule, and that can be used to identify the long white matter tracts that underlie cortical function. In order to analyze these data, one can use a seed. One can use an fMRI activation seed, for example, the motor cortex. One can use an anatomic region, typically 2 regions, to find out where the tracts go. For example, for the visual tracts, one uses the calcrine fissure and the lateral geniculate body. One can also look at white matter area where you know the tracts pass through and count the number of strings. What is particularly problematic is how you measure tracts. One can look at the fractional anisotropy and or its asymmetry. One can look at the volume of a tract that is cross-sectional or tract volume. One can look, as we have talked about in an anisotropy measure, one can also look at the string number. There is ongoing debate about how reproducible and how valid each of these measures are, and that remains a topic of ongoing investigation and discussion. So that concludes the section on structural MRI analysis. There are also PET methods. This is positron emission tomography. These are radio tracers that are tagged to compounds designed to target a physiologic process. This can be blood flow, looking at water, metabolism using fluorodeoxyglucose. One can look at a neurotransmitter precursor, such as alpha-methyltryptophan, or one can look at receptor binding, either an agonist or antagonist, such as clonazepam or FC-Way. With PET, these things can be measured, they can be quantitated, the activity can be averaged over time, and one can also follow the kinetics of activity over time. This is particularly true for receptor ligands, where you can do binding studies and displacement studies that may be informative. And again, they can be quantitated. The information gained from PET methods is limited by the tracer half-life. So O15 has a half-life of 90 seconds. This is a marker of water. You can look for an increase or decrease of signal. The 18 fluoridated compounds have a half-life of approximately 90 minutes. The classic compound for this is FDG PET, where you're looking for a decrease in uptake, most typically, and the carbon compounds have a 20-minute half-life. Example here is flumazenil or alpha-methyltryptophan. For flumazenil, one generally looks at a decrease in binding in alpha-methyltryptophan and increase in uptake in the epileptogenic area. All of these studies require a cyclotron. Because of the fluoridated compounds have a long half-life, sometimes these compounds can be flown in quantity to an off-site institution, but the others require an on-site cyclotron. They also all require image acquisition shortly after injection because of their limited half-life, which is in contrast to Spect studies, which we will mention subsequently. So PET can be read on a visual basis, and to do this, the images should be blinded. The raters should assess this. They should be trained, and you have to provide a measure of agreement between raters, such as a kappa value. One can analyze this qualitatively or quantitatively using a region of interest, as you can for MRI, and sometimes these regions are based off of MRI structures. That can be anatomical or it can be regional. When you have binding studies, you can compare signal to a silent or stable region not implicated in the disease process. So, for example, with FC wave, which is a 5-HT1A ligand, the 5-HT1A receptors are not expressed in the cerebellum. You can look, or others will use, for example, the calcrine cortex, not typically involved, to look at a ratio of signal uptake. You can also conduct voxel-based, computational-based methods based on normal data. Here, you analyze in common space signal that falls beyond 2 to 3 standard deviations as being significant. So again, you get the control population in native space, and you compare on a voxel by voxel basis how a given individual differs from that control population, either with an increase or decrease in signal. One can also look at the volume of activity or the peak activity of the abnormality. SPECT is single photon emission commuted tomography. This is similar to PET. However, this method cannot be quantitated. They are mostly based on technetium-99 ligands, which have a half-hour of 6 hours. The ligands used themselves may have a shorter half-life, but the half-life of the tag is 6 hours. In theory, this has the same range in physiologic processes as the PET ligands, but in practice has been limited to cerebral blood flow studies using ECD or HMPAO as a marker of blood flow. You can image hours after the injection of the compound and its uptake. As I stated before, one cannot quantitate these data. However, these are stable to transport and do not need an on-site cyclotron for synthesis and injection. Both PET and SPECT are radioligands, therefore they fall under radiation safety monitoring and rules. There is a need for radiation exposure dosimetry before human studies. Irradiating children is particularly challenging and problematic for new ligands, as one is allotted 1/10 the dose for adults, and normative data 1/10 the dose as you would for adults to minimize radiation exposure. Therefore, it is particularly difficult to obtain normative data for obvious reasons, and also the lower dose increases the challenges of signal-to-noise generation. Normative data has been obtained on siblings in patients who are in fact found out to be normal or using the good hemisphere as the control. In younger populations, again, all of these have been tried in various formats but remain problematic. We'll now move to FMRI and structural and functional connectivity. So these studies are usually based on fMRI using the blood oxygen level dependent technique. One can also use quantitative arterial spin labeling techniques as well that provides particular quantitation of blood flow measures. I will not be discussing the physiologic basis of this technology. FMRI is typically conducted to identify areas that underlie a specific neurologic function, such as motor, language, memory, and so forth. They require a task design. There are two conditions at a minimum, an experimental condition and a control condition. Often this is rest. For individual analyses, it is important to have a study design that has a clear contrast in differences between conditions. For cognitive sciences, one only requires little differences between the task and the experimental condition because these data are analyzed as a group. There are a bunch of assumptions that are embedded in any design that you have, and you have to be wary of assumptions and how they may affect your data. Important are the ability of a patient or subject or a child, for example, to do the task. So, for example, word generation tasks and semantic decision tasks can be done in children over the age of 7 years. They are problematic in children younger than 7. Word definition decision tasks can be done down to the age of 3. When you do generation tasks, there is a different activation pattern for when a decision is required, as that tends to recruit Brodmann's area 47 bilaterally. And then there are challenges to overt and covert task designs. Overt is more easy to monitor, but induces head motion and movement. There are specific analysis approaches that you can do to identify the artifact induced by movement to remove that from the signal. Most fMRI studies are done covertly, and you can do a button press to monitor response or out-of-scanner performance if performance is necessary. This is an example of the importance of the control condition. This happens to be my brain. So in the top row, we had assumed that in listening to stories, an appropriate control condition would be the background noise of the scanners. Thus, it was just silent crosshair fixation and rest. This elicits bilateral activation because there is insufficient control for first and second order auditory processing. And this image left is left and right is right. So in order to address that, we used a reverse speech control, which effectively controls for first and second order auditory processing largely in the right hemisphere. But in order to determine that something is or is not speech, there's also loss of signal in the dominant hemisphere. Thus, the laterality is strengthened by the strategy, but the overall signal volume is diminished. The designs used for functional MRI are boxcar design, usually 20 to 30 seconds for each condition. Typically, one requires a minimum of 3, typically 4, and occasionally 5 or 6 cycles. So the conditions are presented in each block over several seconds. One can also look at fixed event-related designs where there is a fixed event, followed by signal acquisition for the next 5 to 10 seconds, as the peak bold response typically occurs 3 to 5 seconds after the event. This, however, introduces a particular steady bias if the time is constant between fixed events. Therefore, one can also jitter this to have a rapid event-related design where you then have to have computational modeling to deconvolve the signal response in response to the presentation of the events. There are a variety of statistical analyses and approaches that can be used to analyze fMRI data. So there is the Kolmogorov-Smirnov approach, which there is a t-test, there is multiple regression, and there is cross-correlation, and there is the SPM, which is a general linear model. They all have a variety of assumptions about what they do. They are all very much threshold dependent, which, although there are p-values, is often arbitrary. But the bottom line is they all yield very similar results for the same data set or data sets as exemplified here. So for analysis methods, one has to select a statistical threshold. This can be particularly challenging for grants and for papers, but one needs to have a common threshold. There are methods of statistically varying the statistical threshold by by certain approaches that do this on a fair basis. One can look at volume of activation. One can look at magnitude of activation. One can look at one can do region of interest analysis based on activation maps, so only look at the areas activated, or one can look at activation within a particular anatomic region. One can also do voxel-based analyses, as we have discussed previously, for structural MRI as well as for PET and SPECT data. One can also look at signal differences between two or more areas. This is typically done for connectivity. And one can also analyze the data in really two opposing ways. One is the way a radiologist views the data. The other is the way a cognitive scientist views the data. So a radiologist will look at the pattern and then explain what is happening based on knowledge of anatomy and functional organization. A cognitive scientist will have a hypothesis about what should or should not be activated and driven by a particular measure. So I will now spend some time on structural and functional connectivity. Ultimately, all functional studies must be based on an anatomic relationship between the areas and structures studied. The elements for functional connectivity also hold for structural connectivity, as you're looking at how two areas are connected by white matter tracts, usually tractography and fractional anisotropy. Functional connectivity can be bidirectional, and this only looks at what connective measures are between two areas. It does not talk about directionality. To look at effective connectivity, which has a measure of direction, there are three methods which have been used to do this. This is particularly important for functional connectivity, and that is causal connectivity analysis, which has a Granger causality, structural equation modeling, and dynamic causal modeling. If one does this, they are tricky to use and they tend to be unstable, but one should persist with one of these approaches. The other is to look at network topology, and this is graph theory analysis, which is currently popular. There is vocabulary to connectivity, and these include, and I refer you to Spore's review of the terminology for connectivity, which I find most helpful. So there are hubs, which are brain regions that conduct whatever process is happening, and the edges are the paths between these areas. There are local network properties. These are defined by the terms local efficiency, clustering coefficient, and modularity metrics. And there are global network properties, which include global efficiency and betweenness centrality metrics. And this is the distinction between segregating processing within a narrow region versus integration across a wider range of brain regions and networks. Altogether, these are considered to be small world measures, and this is the language of graph theory and metrics. So, for example, here are modules showing two areas with small nodes and a large hub, and these involve the shortest path, which is the characteristic path length, or clustering coefficients between regions that are implicated in processing or in this particular process, and this is the basis of the clustering coefficient. One also has hubs nodes, which are between these regions, and that is the betweenness centrality or other centralities. One can look at the motif, which is the anatomic or functional motif in the back and forth movement of this activity, and the degree, or the degree centrality, which is the participation coefficient of degree contribution. Down below is how you generally look at these measures. They can be highly ordered, or they can be very random. These are the two extremes. Typically, there's something in the middle which is called small world, which is a mixture and balance between completely ordered or segregated to completely random or open networks. And again, I refer you to Rubicon and Sporn's article in Neuroimage. One can also look, these are the terms which have been used. A highly regular network has high local efficiency, a high clustering coefficient, high modularity, little in the way of global efficiency, and increase betweenness centrality. And random networks have low local efficiency, low clustering coefficients, low modularity, high global efficiency, and low betweenness centrality. Complex networks are small world networks which are in the middle, and one can use these various measures to determine where they fit in this broader range. And below this, you see the cartoon from the previous slide. So collecting data, one needs a high-resolution T1 anatomic study. One requires DTI. The more directions, the better, typically over 38. And this is what you need to identify white matter. If you are doing white matter connectivity, which is very similar to what we have discussed for functional connectivity. Most connectivity data, while it can be done or conducted in task-based studies where you're looking at connectivity between regions implicated in a task or a process, current interest is in resting state studies, which begs the question of what resting state may be, as that may be anything, and it is effectively an unmonitored acquisition of data. There is an increasing trend to have people watch a similar, for example, nonverbal movie, so at least the input has greater commonality for contrast. But again, these are assumptions that may be at cross purposes to your design. The most rigorous connectome data metrics standards are 20 minutes of resting state. Other centers have identified significant findings with as little as 5 minutes of data. It is typically better to have at least 5 minutes of data collected, and if you can get closer to 20 minutes, that is better. These studies are highly affected by motion, which affects long tracks more than short tracks, and is absolutely essential to keep motion to a minimum. The data are often scrubbed, and often in effect to eliminate the effect of motion on signal. One can obtain these studies with sedation. This is true for functional MRI as well as for resting state. One can use propofol in this setting, but if you use an anesthetic dose of propofol, then you will eliminate the functional data for functional connectivity, although you will still be able to obtain or have very high quality structural imaging data for what you wish to achieve. The propofol can be titrated based on a passive motor movement task, so that you have titrated the propofol so that you get signal from moving the limb, so then you know the appropriate level of sedation to obtain functional data. Then there are control population studies require control populations, and there is always an ongoing discussion about what the best control population is. If you have an intellectually disabled population, typical controls are often used, but sometimes you require another population which has a different entity but which has similar developmental or cognitive challenges. But all of these studies require control populations. Connectivity analysis using independent component analysis or principal component analysis can identify several but finite system of distributed networks, and those are shown here, but they do not show language, which is intriguing. So often in resting state studies, you are then looking to identify the various networks at play, and then to look at their graph theory metrics to determine to what extent they have been perturbed or not perturbed by the disease and how they may be altered. So for connectivity methods, one can use a seed or a region of interest-based analysis. Here one can look at an anatomic region. For example, most commonly is the hippocampus, the temporal lobe, or the suspected focus, and one can then look at a seed between 2 points, or look at a seed and to see where the connectivity goes. And again, this may be functional or this may be structural. A seed can be a point. It could be an anatomic area. It can be a region based on functional activation, or it can be anatomic, as we have noted. As a rule, the smaller and more focused the seed, the better and more stable the data. You can also use a seed based on an EEG spike or FMRI EEG-based region, as, for example, has been done for temporal lobe epilepsy and childhood absence epilepsy. One, as I have noted, can look at connectivity between two seeds or two regions. One can also identify a seed and see where the connectivity goes, or whether it is increased or decreased from a point to a region or to another point. One can also look at between paired regions, region of interest, or within a particular network, and those are the regions as above, and one can consider the size. Connectome maps have a variety of maps, some of which have very large regions, some of which have very smaller sub-regions within Brodmann's areas that range anywhere from 40 regions to over 180 regions for multiple comparisons and analysis. One can use voxel-wise brain region parcellation connectivity. Here you can look at local connectivity compared to distant connectivity, and one can also look at the size of the modules that one uses. Again, there is Brodmann's, the Oxford, Harvard, and other areas, and they vary, as I've mentioned in the previous slide, in the size of their functional regions. One can also look at a data set and look at either ICA or PCA analysis. So here you can look at a abnormal resting state fMRI region, so what is resected or what you are leaving behind. Typically in independent component analysis, one is looking for asymmetries. In addition, there are graph theory metrics where you can look at measures of integration or segregation, as we have discussed previously. I would like to close in the next few minutes about study design challenges, here focusing on modified Strobe elements for imaging studies and potential solutions to imaging studies. So there are ubiquitous study design challenges as pertains to outcomes in imaging research. So in outcomes research for epilepsy, you have to determine how you are agreeing with other measures. So for example, as a marker of the seizure focus, one can use surface EEG, one can use intracranial EEG, or one can use seizure freedom as your criteria for your measure and your comparator. When using seizure freedom, must be cognizant that surgeons differ, and also there may be constraints on resection. Therefore, eloquent cortex may limit the resection. So you may in fact be correct into the area that you are resecting, but because you cannot resect all the cortex because of eloquent function, you will not get seizure freedom even though you are in the right location. In some settings, reduction in seizures may mean that you are in the right place for the reasons described above. Outcomes so before talking about outcomes for epilepsy control, there are also outcomes for language and memory performance. These are popular with functional MRI studies, and here you can use as your comparator the WADA, electrocorticography, or post-operative measures. They all have strengths and limitations. The WADA has a variety of limitations, as is a very short time period. The ECOG can only assess the area of one limited region of the brain, for example. There are challenges to analysis. It is important to minimize variables in repeated analysis, so it's not, one can find studies of 15 patients with 10 different measures, and of course this loses power. You also need to address normal and pathologic variability, as one cannot escape heterogeneity, and this is important for generalizability of observations. And you need to have a measure and standard for the comparator based on EEG lesion or outcome, among several others. Other study design challenges point to limited statistical power. The number of subjects for new technology studies is rarely over 20 people. Usually the early studies involve 5 or 10 or 15 patients. It is only in later studies that you get to substantial numbers, and that limits your power. They are also limited by follow-up duration. Sometimes there is no follow-up, That duration may be 6 months or it may be a year, and sometimes this needs to be longer. There is the ever-present pace of technology and change. MR scanners are constantly being upgraded and adjusted, and that means some of the parameters which you have used will invariably have been changed. That difference in technology may introduce a bias or a change in the standardization of what you are trying to assess. We have discussed the homogeneity of study populations and generalizability of findings several times, and I will continue to harp on this throughout the remainder of this talk. Control populations are often lacking, but they are necessary. They are rare, and they are often small. If you are employing voxel-based methods for DTI or FMRI, you are more likely to have control populations. The larger the control population, the better. When you have age-based studies, you need to consider the effect of age on these metrics, and that requires larger populations as controls for pediatric studies. And ionizing radiation precludes obtaining true control subjects for pediatric studies. In temporal lobe epilepsy, which is a common topic of image studies, there are a variety of image findings. There are different clinical characteristics, and one needs to look at who does well and who does not do well following outcome. Often there is a lack of multi-site infrastructure. Groups that look at multi-site studies often fuss over differences in technology and scanners, but the variance between the scanners is usually less than the variance between patient populations. And the other challenge is that when you look at multimodal studies, you find multimodal expertise usually is present in one but not the other technology at any given site. Therefore, one center may be better at functional MRI, one study may be better at WADA, one center may be better at cortical stimulation, one study may be better at PET, another in Spect, and so forth. A common flaw of studies is that the diagnostic data are used, or the research data are used in the decision-making process. And you cannot test data independently, which is a prime component of good practice, and you need to have equipoise. One needs to model how new data, so if you have a new imaging modality and you are acquiring data and you find abnormalities, then you really should not be using that data in your clinical decision-making until it's been validated. And if you do so, it's going to affect it's going to have an influence on your results that may be self-justifying. A model how to get around this is to examine how the data changes the decision-making. So you can either look at how decision-making is made in a center that has or does not have this data, or you can present the data to a group at Epilepsy Surgery Conference, determine the decision that would be made, and then reconsider the decision based on the new imaging data, and therefore you could look at the effect of the new data on the decision-making process, but you cannot ultimately know how that changes outcome. There is a bias of patients, for example, in normal MRI temporal lobe epilepsy, which is more challenging even in extratemporal lobe epilepsy. Most studies do not evaluate how this technology changes overall practice, and they do not test when technology is equivalent or redundant or improves care. So there are times, for example, FDG, PET, and SPECT are rarely helpful when an MRI lesion is present, but this is commonly used in this setting, so it's unclear whether that additional technology improves outcome or care or just adds cost to that technology workup. So I'm going to close by going through the 16 modified Strobe elements for imaging studies, and these are outlined in an imaging commentary in Epilepsia. It is critical to have a clear study question and clearly stated study design. One needs a clearly defined study population and where relevant note the study base, and these have to be based on agreed diagnostic categories, and they should include both inclusion and exclusion criteria. I should add that these elements should be central for any grant or any paper or any study that one plans. One needs to have a clearly defined control population, whether this is a typically developing normal population, another normal population, or a patient population. It is always better, whenever possible, to have a prospective data collection where possible following standardized protocols. One can look at retrospective data if you have an objective measure and are blinding people to its interpretation. One needs to test all patients uniformly unless there is a randomized design, which is rarely present in imaging studies. You need to have a clearly defined experimental measure and a comparison or outcome measure. Data analysis should be clearly defined and identified at the beginning of the study, not at the end of the study, preferably an objective measure. If not, you can use skilled visual raters. It is better if a measure of reproducibility is provided. Assessments blinded to patient identity from the rater and from caring physicians is essential. So any experimental measure, the person who is making that assessment needs to be blinded to the patient identity from the caring physicians, and the caring physician should be blinded from this as well. There needs to be an assessment of population size and homogeneity, or include heterogeneity in this design, and address this in the power to conduct the study. For a surgical series, it is best to have pathologic confirmation. For outcome, follow-up at greater than 1 year is preferred, and that should be ascertained by a person without a vested interest in the outcome. It is important to state how the data were or were not considered in the decision-making process, and we have talked about study designs involving decision modification or comparing centers with and without that technology as examples for how to address this issue. It is important to be able to provide the data in tabular form on an individual basis for external assessment. The data analysis should be conducted with an appropriate statistical test, validity, sensitivity, and specificity, and or a comparison with other method or methods. One needs to state the practicalities and limitations, including sources of selection bias or insurmountable factors modifying the above statistical measures. For example, if you have a known incomplete resection, you might not expect complete seizure freedom, but that may not negate the importance of your observations. For surgery, you need surgical outcome. You need to list seizure freedom and the degree of seizure reduction in those not seizure-free. So those are the 16 criteria. There are a variety of potential solutions. And again, I would reiterate there must be an experimental question or a hypothesis. You need to have a study designed to answer the question. The study needs to be appropriately powered. You need to account for heterogeneity when possible. You need a clear statistical approach. You need to be aware of your limitations. And you need to identify conflicts of interest and sources of bias. They cannot be eliminated, but they can be identified and constrained. And with that, this is the conclusion of the talk. Thank you very much for your attention. And following are references which are provided for you. Thank you very much.